You're listening to the Radiology News Network, RNN.
Welcome to a new episode of the Radiology News Network. We adopted a new style, as you can hear, with specially composed music. This is performed by Patrick Brouwer, one of our interventional radiologists in the field of neuroradiology. So thank him for that. It makes it more vivid. Today we have a special guest, and I will introduce him later. So I hope you will enjoy this podcast and also the new music.
You're listening to the Radiology News Network, RNN.
So welcome, Professor Patel. I hope you're live now in the broadcast.
Welcome, thank you.
So maybe the first step is to introduce yourself, your center, where you're working, and maybe also a little bit about your background, where you did your study of medicine.
Absolutely. I'd be delighted. My name is Maitray Patel. I'm currently a professor of radiology at the Mayo Clinic in Arizona. I actually trained by going to medical school and college here in the U.S. At the University of Michigan. And after Michigan, I went to do my internship and residency at UCSF. So I was at UCSF as a radiology resident. Subsequently did my fellowship also at UCSF in both ultrasound and in body MRI. And then subsequently stayed on at UCSF as a faculty member, primarily at the San Francisco General Hospital, where I was the chief of ultrasound for almost 5 years. Then subsequently in 1998, my wife and I left San Francisco to come to Arizona to join the Mayo Clinic here in Arizona, and I've been here for 22 years.
That's amazing. Yeah, I'm also already for 25 years in Leiden, so
yeah, it's a long time.
It's a long time. Well, you published very interesting papers, of course, a lot of them, but in this podcast, I would like to focus on two of them. And the first one is the most intriguing one that was published recently in Radiology 2020 edition. And the formal title is Radiologists Make More Errors Interpreting Off-Hours Body CT Studies During Overnight Assessments as Compared with Daytime Assignments. Well, that's a very intriguing title. I also had to do some of that work during night shifts when I was a resident. So I know the feeling that at 3 o'clock at night, maybe you're not that sharp as 3 o'clock in the afternoon. But you try to quantify this effect. So can you tell me a little bit about the study setup, the design?
Absolutely. So this was really a unique opportunity at our facility because we had, although we are an academic center and a subspecialized department, meaning that we have a dedicated ultrasound division, a dedicated cardiothoracic division, etc. We did not have a radiology residency. So when I first came to Mayo in Arizona, we've been growing. The whole clinic here, everyone's familiar with the Mayo Clinic, and its headquarters are in Rochester, Minnesota. But in the early 1980s, the Rochester headquarters decided that it would facilitate patient care for their model to have two ancillary sites. And so they created one site in Jacksonville, Florida, and one site in Arizona. And so when the site started in Arizona in 1987, there were only two radiologists then. But over time, as the clinic grew and the goal was always to grow, it became bigger. And so when I joined in 1998, I would think I was the 17th radiologist, and now we have over 50 radiologists. So it's been a continuous growth. But the upshot of that is that we did not have a radiology residency for many years, but we did have subspecialty expertise. And so here in the United States, we have this fellowship model where residents, after doing a residency here in the United States, can do extra training with subspecialized radiologists in a particular area. And since we had subspecialty divisions, we had fellowships. And so we were able to recruit over the years people who would come typically only for 1 year to do subspecialty training. And the three areas that we focused on because of the popularity and because of our particular expertise were breast imaging, musculoskeletal imaging, and body MRI. So we would have fellows come every year in those three areas. Well, as part of their responsibilities, these fellows would take night call for us. When they were doing, so these are individuals who had completed a radiology residency. They were board certified or board eligible. They had all passed their residency, and now we're doing an extra year of training. And when we had them do the night shifts, there were varying styles, but essentially the night shifts were from 8 p.m. to 7 a.m. I should go back. They not only did night shifts, but they did after hours shifts as well. We call them collectively after hours shifts. So part of those after hours shifts would be 8 p.m. to 7 a.m. because we would have subspecialty primary faculty members interpreting up till 8 p.m. And then the other after hours shift would be on the weekends or on holidays. And so on that shift would be 7 a.m. To 6 p.m. And so and then on the weekends, obviously it was 6 p.m. to 7 a.m. So there was a little bit extra hours on the weekends for the night person. Anyway, the upshot of this is that we, as opposed to most academic centers in the United States, since we didn't have residents, we had fellows who were already finished residency doing these general radiology shifts. By general, meaning they were charged with interpreting all the examinations that came through, not just in their area that they were training. And because we're an academic center, we would always reread them the next day or within, our rule was they had to be reread within 10 hours. So, for example, on a Saturday, if a fellow had interpreted a rule out ectopic pregnancy case at 10 in the morning and dictated it, I, as the ultrasound attending, would review that before the afternoon. And typically, the faculty at home would log onto the computer and review every few hours. And so during the daytime, it was, perhaps 2 to 3 hour delay in terms of the review. In the evenings, obviously, up until about 11 p.m., the faculty would review, and then they would put it away and then look again in the morning at 6 or 7 in the morning. So there was a little longer delay between the interpretation and the review. But because, obviously, we're a center where people make decisions based on radiology, those reports that the fellows were dictating were not preliminary reports. They were complete final reports. They would go out into the PACS. And then when we reviewed them, if we thought there was a discrepancy, we would change the report. We also had a computer-based, we wanted to understand, primarily to make sure that we were being true to our colleagues in other disciplines, we kept track of how many times we said that the fellows had made mistakes, how many times we said that the diagnosis changed or that whatever we added to the report would impact the patient's care, either acutely or a follow-up care, meaning if the if the fellow had said, hey, there's a hemorrhagic ovarian cyst in the left ovary, and you should get a follow-up study in 6 weeks. And when we looked at it, we said, well, this hemorrhagic ovarian cyst is only 3 centimeters. And so, no, the patient does not need a follow-up study in 6 weeks. This can go away by itself and without any further imaging. We would change the report and the recommendation, and we would mark that off as a change in the care because the fellow had recommended a care that we didn't think was needed. And there were other instances where they may not have seen things and we had identified things. So there are all types of potential errors. In addition to those types of errors, there were also style changes. These were where we might have added something to the differential diagnosis, or we may have changed the actual wording of the report. And those were also kept track of, but those were not part of the study at all. So we did not look at those sorts of changes. We only looked at changes where the radiology attending said that there was a change to the care. And then we would, each division would review those changes at a quality assurance meeting every quarter for each division just to see what we could learn. But we kept track of these.
You classified all this as an error. But did you also specify or have different layers of errors or different levels?
Yeah, that's a good point. We did not formally do that. So if one person had an error that affected care, for example, my hemorrhagic ovarian cyst example, that technically is an error. Somebody had recommended a follow-up study, and the attending said, you know what, follow-up study is not needed. So that changes the care of that patient in the future. Having said that, one could argue that has a relatively minor impact on the patient, because the harm is one extra test. What is the harm of an extra test? Well, there is some harm, but it's not a huge harm, as opposed to, let's say, somebody missed a pulmonary mass, in the lung base on a body CT. So let's say they looked at an abdomen pelvis CT, and there is a lung mass in the lower right lung, and they did not see that. And then obviously if the attending saw that and said, hey, there is a lung mass, so yes, there's no cause of diverticulitis, but this patient needs to get a workup of that lung mass. Clearly the impact of that error is higher. So there are different tiers of layers, but we did not actually take the effort to grade those. And we also did not record the number of errors. So if you had one error, it was put in the error bucket. But if you had 10 errors, it was also put in the error bucket. So we didn't,
Yeah. And you analyzed the period between July 2014 and 2018, I see.
Right. And so we did it in that period because starting in July 2018, we had our residency set up. We were creating a residency, and now we have trainees that are residents doing these shifts, not fellows, not people who had finished. And so that was a natural break for our analytical period.
Yeah.
So to get back to the study design, so we had all this data, and then we thought, well, let's take a look and see how well individuals did when they were working during the day compared to how well the same individuals did when they were working overnight, to see if there was a difference.
Yeah. And in total, you had more than 10,000 body CT studies interpreted by 32 different radiologists. So can you comment a little bit on the results? What was the outcome of the whole effort?
Sure. So when we analyzed the data, what we found was that the rate of error overall was relatively low, 2.4%, 2.5%, something like that. But that if you took a look at the time periods and you classified them just in a binary fashion, day versus night, what we found is that the error rate for the 10,000 exams total was much lower in the daytime than in the nighttime. And by much lower, I mean 1%, which doesn't sound like a lot. But you have to remember that many of these studies were not abnormal. So what we didn't test, and what, obviously the degree of the percentage of what you're going to find is going to depend on the severity of the cases that you're seeing. The more complicated the cases, the more errors that you would have. So there's going to be a number of cases that are easy. So, rule out appendicitis in the middle of the night will be relatively easy, as rule out appendicitis might be during the day. Or, look for renal stones in the middle of the night would be relatively easy. So we had a 1% difference in the error rate, meaning that when these individuals were reading from 7 a.m. to 6 p.m. during the day on holidays and on weekends, they made errors at a collective rate of 2%. So 1 out of 50 studies were marked as having an error. Whereas at night, if for the collective cases that were done overnight, which was from 7 p.m. to from 8 p.m. generally, or 6 p.m. depending on whether it was the weekend or the weekday, to 7 in the morning, their collective error rate was 3%. And then we substratified that more and found that the biggest error rate was actually between midnight and 7 in the morning. So any study that got interpreted between midnight and 7 in the morning was had a 3.7% chance of having an error, versus the cases that were read from 7 in the morning to 12 noon, which is the person's fresh. That error rate was less than 2%.
Of course, we all would like to have a 0% error rate, but if you are realistic, what percentage can be used as a real cutoff to say, well, this is really not acceptable?
Well, so again, that really depends on how many normals you're doing. If you're at a center, like our center has some fairly complicated cases. And so, we have a cancer center and a number of patients come in, and there are some strange things. And then on top of that, there are many findings. And so, as you know, we were asking our fellows to dictate, these radiologists to dictate complete studies. And so they were responsible and they were held accountable for, everything on the images. And so as a result, the more complicated the cases, the higher rate of misses, I think. And I think we've shown that in the past. We've done some other work where, if you have normal cases, your error rate should be 0. If everybody's normal, it should be 0%. But if everybody is sick, very sick, your error rate might be, higher. So there's not a good number.
Yeah.
It would vary from center to center.
And if you see all these numbers, what should be the consequence of these findings? Because you have to report sometimes in the weekend and at night.
Right.
But what are the practical implementations of this result?
Yeah, that's a very good question. So what we wanted to, we just wanted to present the data so that people understood. And it actually, sometimes when you present this data, like I've gotten some feedback saying, well, that's obvious. I mean, if you're going to wake up in the middle of the night, you're not going to be as good. You're going to miss a few things when you're tired as compared to when you're not tired. And I guess that is sort of the point. I mean, in our study design, we actually had it so that the fellows who were reading overnight were theoretically rested, meaning they could only do that 5 out of 7 nights. They had to have 12 hours off before they started work. So they could not work during the day. And they could, theoretically they should be rested. Now, it's very hard, I think, for individuals to switch their circadian rhythms so that, they do that. And everybody has a life. And so we don't know who had a child that they had to, they couldn't sleep during the day because they have a child at home or whatnot. So there are obviously individual circumstances who will affect how rested you can be for a night shift. Having said all that, part of it is sort of a, this is obvious. But the real implication, I think, is the notion that for people who generally work during the day, when they work at night, perhaps that work should have more scrutiny. The practical implication for so I'll tell you the challenge at our center is that the emergency room physicians do not like us reviewing the cases later because they want the best care, obviously, for the patient. But at the same time, it puts them in a weird situation because they may have acted on one interpretation and then we're telling them, 5 to 8 hours later, no, we think there's a different interpretation. And so then we have to contact the patients, have them come back. The emergency room physician may feel like they have to put something in the note, and oftentimes they do. So, there's a medical legal aspect to this that is perplexing. So we've actually had emergency room physicians, and our emergency room department says to us, well, we would prefer that you not review the studies at overnight. Just have somebody who's, reasonably well trained read them out in the middle of the night and don't have them reviewed. Now, that's usually, in an academic center, usually because you have a resident reading in the middle of the night. You certainly could take the approach that, okay, we'll have a faculty member person read in the middle of the night. And our point was that our actual fellows were board certified fellows. They had completed a residency. And if we hired people to work just at night, most likely it's going to be these junior types of people who aren't subspecialized yet and who are working, at different times than they're used to working. And so we think it's actually in the patient's best interest to get that second interpretation in the morning with a fresh pair of eyes so that we can, pick up any errors. But that's the real question is, do we have a subset of patients who should be looked at again? And that's a tough question, because obviously there's more effort. We're not getting paid more to look at it again. So there's a resource issue. And then you can make the same argument. Well, why would we accept a 2% rate during the day? Those should be looked at again. And so I do think that, to some extent, AI may be a way out or pathway to quality improvement in this method. I mean, it may be that, for example, radiologists who read in the middle of the night, or once AI is really good, let's say, those cases would go through the AI computer, and then anything that looks like it might have been missed could be looked at by a second reviewer, but anything that looks like it hasn't been missed, might not. You could flip it as well, I suppose, but I mean, that's one option.
Yeah, and this is of course true for the emergency care, but can you also extrapolate this knowledge to more elective or planned care? Is it? Do you think it's the same?
Well, I mean, there's always going to be errors. So there's two aspects of this. There's an inherent error rate, and then there's the error that's due to working outside of your normal hours. So theoretically, elective cases would not have that second component. Yes, there's always going to be errors. The question, though, is that we were looking at in our study was, what additional errors can we attribute to the fact that we're working overnight? And in our case, it looked like 1%, which is actually 2 to 3%. It's a 50% higher error rate, so.
Yeah, it's still very intriguing, all these results. So thank you very much for this contribution to the literature.
You're listening to the Radiology News Network, RNN.
And that leads us to the second paper, because you have been very, very active, Professor Patel. This paper is also published in 2020. I see that it was submitted in 2019, but it's now published in the Journal of American College of Radiology. And it's also a very practical paper. So that's what I also like about your work. If you read the papers, then you know what to do when you are back in your own hospital. And this paper is about the management of incidental adnexal findings on CT and MRI, and it's even a white paper of the ACR Incidental Findings Committee. So can you also give a summary of this interesting paper?
Sure. Just by way of background, I have been very active in the Society of Radiologists in Ultrasound, which is, what I do all the time is ultrasound. But as part of that, back in 2008, we, the SRU, had a consensus conference to get together various stakeholders, GYN, pathology, others, to look at incidental adnexal cysts seen on ultrasound. And so I was a major part of that group, and we came up with some recommendations. As a consequence of that work, I was approached to say, hey, we need some sort of management framework for what we do when we find these things on CT and on MR. And so would you, for the ACR, which I'm also a member of, lead that committee? So in 2013 was when our first paper came out about how we might frame that management discussion. And then this recent 2020 revision is really an update of that. And so it was, again, a collaborative effort. In this case, we had one gynecologist in the committee, and we had Dr. Some people from the ACR who were more policy sorts of experts, and then there were a whole host of really GYN imaging experts, and also some not GYN imaging experts, but CT experts. So, for example, Dr. Perry Picard was on the committee. He's not really a GYN radiologist, as everyone knows. His claim to fame is in the GI area, and he's does a lot of CT colonography screening. But as part of that CT colonography screening experience, he has a lot of familiarity with incidental adnexal findings on CT. And so we got together, and our job was really to evaluate the literature, to see what had changed, if anything, what new evidence could be brought to bear on this question, and then to create recommendations, and that's what we did.
Can you give a summary of the nice figure 1, because that gives a flow chart of what to do?
Sure.
And also comment a little bit on the reasons why you choose for that. For example, how to measure it. What do you mean with one bigger than 1 centimeter? Is that the biggest, smallest? Right. Is it round or the shortest, longest, or all these practical problems we always have?
Yeah. So we wanted to make it simple, and so instead of using volume or average measurements and so forth, this is basically the largest measurement that you find for the round or oval cyst. So first of all, at a high level, when you see something on CT, it really falls into one of 3 buckets. It can be a characteristic abnormality, so it might characteristically be a dermoid, a benign cystic teratoma. It might characteristically be a hydrosalpinx. It might characteristically be a cancer. If you have a characteristic set of features, then you're going to manage it based on what that diagnosis is. And so one arm of that algorithm is, when you're looking at something, if you can make a diagnosis with reasonable confidence, then manage it the way that's managed. And our work really did not address, to some extent, we didn't really change how that's managed. And so that's one arm. The second arm is, it looks like a simple appearing cyst, meaning, and we had to define what simple appearing cyst meant. And so in our definition, a simple appearing cyst was basically, it was, round or oval in shape, had Hounsfield units of less than 20. It had a thin or imperceptible wall, obviously no solid components, and fluid attenuation, essentially. And so if it was a simple appearing cyst, and at less than 10 centimeters, then we have a management algorithm for that. And then just from back to the high level, the third arm is, if you don't know what it is, and you can't say with confidence that it's a simple appearing cyst, then you're going to probably need to evaluate it. And so that was the third arm. You're going to need some more imaging. So focusing on the simple appearing cyst, because that's where I think the thought process was that many people, in the absence of having any guidelines, were asking for additional imaging studies, ultrasound generally, on patients who had what might be expected to be a normal finding in every premenopausal patient, certainly every month, a dominant follicle. And so people were, probably overusing imaging, or even if they felt like there's nothing wrong here, they didn't have any framework or any guidelines to suggest, hey, I'm in good company. If I don't ask for a follow-up here, I'm not going to be held accountable for that sort of decision because it met these criteria. So we wanted to give people that sort of reassurance. But also the literature now shows that simple appearing cysts on CT, the ones that meet those criteria that I talked about, pretty much behave like simple cysts on ultrasound. So there's a difference. Simple cyst on ultrasound is also round or oval, has no internal echoes, has no solid component. But this is a sonographic characterization. On CT and on MR, we use simple appearing, just to distinguish between those two. And we have years of experience about simple cysts on ultrasound. We have less experience on really characterizing what happens to simple appearing cysts on CT, but now there is some evidence to suggest that if it looks simple appearing, it acts like a simple cyst on ultrasound. And because of that, we're recommending that, much in line with the SRU consensus statement, if you're premenopausal, or if you don't know the menopausal status, you're less than 50 years old, because the average age of menopause, although it varies in different countries, in the United States, it's over 50, it's like 51. So if you're premenopausal or less than 50 and you have a simple appearing cyst that's less than 5 centimeters or 5 centimeters or less, you can assume that this is, assuming it's an incidental finding, that this is going to be something that is not going to meaningfully impact the patient's care. It's either a non-neoplastic cyst, most likely a physiologic cyst. Could it be a benign neoplasm? Absolutely. It could be a cystadenoma. But as an incidental asymptomatic finding, one wonders whether you even need to do anything about cystadenomas. If they're not causing the patient any symptoms, they have no risk of going on to malignancy, because now we know that the vast majority of ovarian cancers arise from stick lesions, from the fallopian tube, not from the ovary itself, from the cells that overlie the ovary that are actually fallopian tube in origin. So if you're premenopausal and it's 5 centimeters or less, you can ignore it. If it's over 5 centimeters, then you will probably get a follow-up. But one of the things that we did in this instance is that if you had, if you had an MRI, not a CT, but if you actually have an MRI with contrast, and you've evaluated this thing in many planes, and it's a simple appearing cyst, you really didn't need to do anything until it was 7 centimeters in size, because we've done a very good evaluation. And one could argue that ultrasound is not going to be of much benefit after a well-characterized MRI. So 5 and 7 are the numbers for a simple appearing cyst in a premenopausal, and 3 and 5 are the numbers for postmenopausal. So if it's on CT, simple appearing, less than 3 centimeters in size, 60-year-old woman, asymptomatic, incidental, you don't need to get further imaging. It can be up to 5 centimeters in that same woman if you happen to have looked at it with an MRI and have the same conclusion. So that was the main issue. And then beyond that, our recommendations were that if you're going to get a follow-up ultrasound, since we already feel like this is a benign mass, it's simple appearing, but it's over your size threshold, get your follow-up in 6 to 12 months. That gives you the best chance to understand whether it goes away by itself, which some of these will, or get smaller, which means that it's non-neoplastic, or if it's getting larger. And then finally, our recommendation was you really need to only follow these for 2 years. If after 2 years, it hasn't changed appreciably in size, and now the follow-up is with ultrasound, of course, but so if after 2 years it hasn't changed, true, it could be a cystadenoma. It still could be a benign neoplasm. But as an asymptomatic finding that is very slow growing or not growing, it's unlikely to have any clinical impact for the patient. On the other hand, if it is growing, you still don't need to continue following it, because you can conclude this is a benign neoplasm. It went from 5 centimeters to 6 centimeters to 7 centimeters. And so I know it's enlarging. And so now imaging follow-up is not really what you need. What you need is to decide whether you need to take it out or not. But if you don't want to take it out because the patient's asymptomatic, then the GYN or the family practice doctor, whoever is following this patient, can make a decision. Okay, I'm not going to get a follow-up in a year because she's still asymptomatic, but I'll get a follow-up in 2-3 years just to see where it's going. Or this 90-year-old patient, I won't get a follow-up at all. This isn't, she has heart disease, she has so many other things. There's no reason to get a follow-up. And so the radiologist is not driving extra care by saying you need to continue to follow this. To what end?
Yeah, and do you recommend a sort of BI-RADS system for this, like in mammography, sort of AD-RADS or whatever you call it?
Yeah, so there is an ORADS now, as you know, and this very much would qualify as an ORADS 2 lesion. Now, we did not work in conjunction with the ORADS committee, and I think in the ORADS, they actually have recommendations for follow-up up to 5 years, which is reasonable. In our estimation, what we felt is for an asymptomatic mass that's incidental, after 2 years, you should either be able to make one of 3 conclusions. Number one, it's growing. Okay, fine. So now manage it as a growing mass. Number 2, it's gone away or it's reducing in size, in which case nothing needs to be done. Or number 3, it hasn't changed in size. So it could still be very slow growing, or it could be something that never grows. And again, you would manage that based on symptoms in our estimation. So we didn't think there was much need for a 5-year follow-up in patients as a routine recommendation for something that has a benign appearance. Now remember, the follow-up is with ultrasound. And so once you have a simple appearing cyst on CT, let's say it's 5.5 centimeters premenopausal, you're going to get a follow-up. You ask for the follow-up in 6 to 12 months. She comes back in a year, and now it's a 5.5 centimeter cyst on ultrasound. Then you'll manage it really based on the ultrasound features. Now the CT is no longer really why you're managing it.
And if we take an outlook to the future, are there any techniques that you think are promising to better characterize the lesions? For example, let's say mapping techniques in MRI or new ultrasound methods?
Yeah, that's an interesting question. I mean, I think certainly for things that are indeterminate, for things that have findings where you're not sure whether this is a meaningful finding or not, there's going to be a lot of new things that will help. Those things could include elastography, they could include contrast and ultrasound, they could include other sorts of new sequences that haven't even been defined yet by MR to understand whether this is neoplastic tissue or not. But when you're talking about a simple appearing cyst, I'm not sure that there's going to be any more imaging characterization that's needed. Because now our experience is that for simple cysts, certainly, and for simple appearing cysts, based on more recent evidence, these things are benign and do not actually progress to malignancy.
Okay, Professor Patel, thank you very much for your contribution in this podcast. So it was a real joy to have you in the show. And I recommend everybody to read those two papers. So I will give the links to it below. So thanks again. And I hope to see you live at some time.
Yeah, that would be a pleasure. Thank you.
Okay, thank you very much. And in the new style of the Radiology News Network podcast, I'd like to end with a new feature called Innovation Leads to Leadership. That are short bursts of information, so you have to listen very carefully. The first one is about the discovery of CT.
RNN. Innovation leads to leadership.
At EMI, there's royal recognition and a meeting with its inventor, Godfrey Hounsfield.
The first body picture I took wasn't myself, and I was very amazed to see what I looked like inside.
The world's first CT patient was scanned in London in 1971.
But it became clinically available in 1973, and the body machine became available in 1975, so 80 years after Röntgen's discovery.
RNN.